Now we are going to demonstrate the technique to do a fill under X-ray. It has a lot of advantages. Our patient has had the lap band for 6 months now, and he's lost 85 pounds. He's coming in for his third fill, and the reason for needing this fill is because he's lost some of the restriction that he had, and he stopped losing weight continuously. So this is the moment to do a fill. For him, is something that we discussed previous to this. As I was saying, the first step to do a fill is to locate the port. When you do this in an office setting, sometimes it's very difficult to palpate the port, and as you can see, we can actually take a look at the port in the monitor. If you're able to see this, we can view the port directly and avoid situations that can make us poke or hit the tubing that can lead to leakage of the system of the band. Now we are going to take a closer look as to how we get the needle in. The insertion of the needle is done with a sterile technique, so we have to clean the skin before we actually insert the needle. And I'm prepping the skin with betadine in this patient because he's not allergic to it. Now the next step is to insert the needle, and this is what we're going to do. I'm going to view the port directly in the fluoroscope, and I'm going into the skin, 1, 2, 3. I went through the skin. I'm viewing the port, and I'm actually watching the port and its membrane as I go through it. So right now, I'm in the system of the band, and how can I tell I'm in the system? Because I'm pulling the fluid that he had out from his previous fills to measure how much he had in. This is very important to check the volume of fluid that's inside the band. In his case, he has 5 milliliters from the prior adjustment. And I'm going to push that back in, and we're starting off at 0.0, meaning this is where he was when he came in. So we're going to add a little bit more fluid, and we're going to do that in a minute. We're just going to change the position, and then we're going to view the actual fill. The next step is to perform the fill. We do this by making the patient swallow a substance that we can actually see go through the band into the stomach, and we can regulate the flow by squeezing the band by adding more liquid into it. The needle's already in, so all I need to do is to make the patient swallow the barium and squeeze the band. At this point, what we try to do is to make sure we avoid any type of obstruction. If the patient winds up with a fill that's too tight, we're going to see the barium slowing down. It won't go through fast enough, and that way we can tell if the fill is being done right or not. This is something you can't do without X-ray. Basically, what's done in an office setting is you make the patient swallow a little bit of water after you perform the fill to make sure it doesn't get stuck. But that really doesn't tell you how things are. With X-ray, you can also view the anatomy, make sure the band's in the right position, and that there's no problems with the anatomy of any nature. So we're going to go ahead and perform the fill. I'm going to ask my patient to drink some barium. He's going to swallow 3 ounces of barium, and at this point, I'm adding fluid into the band system to try to create a partial obstruction to that flow, and that partial obstruction it's going to, in a way, let me view the anatomy of the patient, and right now I'm seeing how it's going through very slowly. That is a little bit too slow. I'm going to back down on some of the fluid, and I'm going to make him drink a little bit more barium, and the barium goes, and I'm going to watch again, see how it flows through the band, and right there, there's no obstruction to the flow of the barium. It's going down nicely, gently. It creates a funnel as it's going through. So this is the amount of fluid that he's going to get for his next fill. And we're already done. I'm just going to close the valve and make sure that he has no trouble drinking some water. I'm going to make him drink some water fast again and to wash down the barium. And I'm going to do another checkup swallow. That one. Goes the water. And now we're going to revise one more time with a little bit of barium, and there we go. It's going to swallow. We're going to watch it go through, make sure that there's no obstruction, that the barium flows down freely, and once the barium is flowing down freely, there you go. This is the most objective way of doing a fill because you're making sure that you're not creating any trouble for the patient. Will it be the perfect fill? We don't know, but for most of our patients, we do know that doing fills under X-rays has cut back on the amount of fills that you get on the first year of having the procedure. Doing fills in an X-ray setting usually cuts the number of fills that you get by less than half. And they're more precise, and again, you can avoid situations that can lead to other complications in the future. The most common one being slippage of the band. If a band is too tight after a fill, it can lead to a slippage. So this is why we highly suggest to everybody to have the fill center fluoroscopy, and they're done very quickly, very simplistically. The only difference is that we need the equipment to do the fill.